I'm Catherine Santoro, Director of Programming at the National Institute for Healthcare Management Foundation, and on behalf of NIHCM, welcome to our webinar today. Today's webinar is the second segment in a four-part series exploring innovative strategies and evidence-based solutions to defy deaths of despair and lift our society from crisis. We're seeing this crisis manifest in rising rates of depression, suicide, and substance abuse, and declining life expectancy in the United States. 1 out of 5 adults in the U.S. experience mental illness, and 1 out of 5 youth ages 13 to 18 live with a mental health condition. Estimates suggest that only half of people with mental illness receive treatment. Turning the tide on current trends in mental health is critical to prevent deaths from drugs, alcohol, and suicide. In future webinars, we'll explore trends in suicide and substance abuse in more detail. Today, we'll focus on efforts to increase mental health screening and treatment, as well as early prevention strategies to reduce risk factors for despair. Before we hear from our speakers, I'd like to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM staff who helped to convene this event today, including Kate Ellis, Caitlin Smith, Alexis Wing, and Kirsten Wade. You can find biographical information for all of our speakers, along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag #DefyingDespair. I am now pleased to introduce our first speaker, Paul Gionfriddo, President and CEO of Mental Health America. Paul is a passionate health and mental health advocate and brings a wealth of experience and expertise from his work in the public and private sectors, including serving on the National Advisory Council to the SAMHSA Center for Mental Health Services. We're so grateful he's with us today to share his perspective on the state of mental health in America, including data from Mental Health America's screening program. Paul?
Thank you very much, and it's a real pleasure to be here with you. I am going to be covering a lot of ground, and I will try to do it pretty quickly. I've been asked to do an overview, and we'll be helping to set up, I think, the subsequent presentations that we'll have today. But I wanted to begin by just noting that each year, Mental Health America writes a report called The State of Mental Health in America. And we draw data from federal sources primarily, and not only for the nation as a whole, but for all of the states. And from our most recent report, some very high-level data reflects something that I think everybody on this call currently understands, and that is that a significant number of American adults, 18%, have a mental health condition. That many of the people, adults with mental health conditions, are uninsured and remain so, even though that number is dropping. While coverage is increasing, access isn't necessarily, because 1 in 5 adults who experience a mental health condition currently reports an unmet need. And there are similar kinds of worries around young people. The rate of youth experiencing a major depressive episode, for example, has increased dramatically over the course of just the last 4 years. And again, the vast majority of youth with a major depressive episode receive no treatment. Part of the problem is that mental health workforce shortages remain. And one of the most promising ways of addressing those shortages, the certified peer specialist, is still getting off the ground. Now, Mental Health America, we are 110 years old. For most of our life was the National Mental Health Association. And we promote mental health as a critical part of overall wellness, including prevention services for all, early identification and intervention for those at risk, integrated care services and supports for those who need them, with recovery as the goal. And understanding that mental illnesses have been, as a matter of public policy, by having a non-clinical standard applied as a trigger to treatment, so-called danger to self or others, mental illnesses have been the only chronic diseases in America that we, as a matter of public policy, have waited until stage 4 to treat, and then often inappropriately only through incarceration. A little bit later on, Kitty's going to reference the 2 systems of care that have evolved in the States. Suffice it to say They've done tremendous harm to people with significant mental health issues. And we can do better than that with more screening and better integration. When screening's offered in primary care, screening for mental health problems, it's perceived as helpful 93% of the time. Primary care physicians are 3 times more likely to recognize symptoms of mental illness and then follow up. Post-screening treatment changes are made a significant percentage of the time, and positive benefits persist over time. Now, the fact of the matter is we are not screening and identifying and serving our kids with behavioral health needs or our adults with behavioral health needs, while screening should be as ubiquitous as blood pressure screening for adults and as vision and hearing screening for children. The fact of the matter is that it's rarely done. And one of the best indicators of this is the evidence from the Department of Education data for the country as a whole, where in 2015-2016, we identified fewer than 350,000 people between the ages of 3 and 21 for special education services on the basis of the SED label. That represents only about 1 child in every 30 who, according to the National Institute of Mental Health, has in fact or will have a serious mental health condition by the age of 18. We've got to do significantly better than that in the area of early identification and intervention, or we lose too many people. Now, much of the presentation that I'm going to do here will be done from the perspective of people, the individual, the patient, for people who refer that way, the consumer. But we were founded, Mental Health America, by an individual, Clifford Beers, young man with lived experience. And so we often look at things not through the lens of the provider or the system, but through the individual, the lens of the individual who is seeking help. And when people first seek help around a mental health condition, they Google terms like, am I stressed or depressed, depression test, or just simply, I want to die. And they don't relate to clinical language. While clinicians will speak of cognitive distortion, stopping stupid thoughts is MHA's most popular webpage outside of screening. Mental Health America offers 4 million screens online that people can take anonymously in those 9 particular areas. And here's some of the general results overview from the screening that we offer. 3/4 of the people who take a screen, we have about 3,000 people a day taking the screen. Screen is positive or moderate to severe for the condition for which they screen. Of that group, 2/3 have never been diagnosed, actually making our database the largest database in the country that is readily available about a health-seeking population that is not yet in treatment, generally, for the services they seek or for the conditions they have. The depression screen, the PHQ-9, is by far the most popular. About half take that, followed generally almost equally by those who take bipolar, anxiety, and psychosis screens. Some of the others come in a little bit lower. 8% of our screens are international. The race ethnicity of our screening population is close to the United States Census, and 35% of our screeners are aged 11 to 17, 32% more 18 to 24. That often stops and surprises people until you remember that half of mental illnesses emerge by the age of 14, 3/4 by the age of 25, making these diseases and conditions of childhood in our country, and our screening population reflects this. Of those who report a chronic condition, which is going to be important for the discussion about integration throughout this hour, 31% report chronic pain, 13% report lung problems, 12% report diabetes. Now that's a general overview of screening, but digging down a bit deeper, if you look simply at the pediatric symptom checklist, which includes 2 of the screens that we have, the parent screen and the youth screen, you'll see some interesting numbers here when you put data from both 2017 and 2018 put together. First of all, on the parent screen, 64% of the young children on whose behalf parents are screening screen at risk for a significant mental health concern or condition. And in the youth screen, 72% screen at risk for a serious mental health condition. Clearly, when people are seeking help, they're seeking help because they already perceive they've got symptoms, they already perceive they need some support and services, but they are not yet getting that. for the most part. And one of the reasons for this, we can see when we dig down into some of the youth screening data even more deeply. It's because for the most part, we wait until there are conduct problems. And when we can observe a behavioral problem within a behavioral health condition, such as danger to self or others, at the deep end of that, that's when we array our services, that's when we step in, and that's when we attempt to change the trajectory of somebody's life. But if you actually look at the way people are responding to questions when they are screening, in fact, in the case of young people, the conduct problems come last. You see more of the dark blue there in the never category. It is the attention problems and the anxiety, depression problems, the internal factors that come first, that they are aware of, they are concerned about, and for which they would be seeking help if we gave them an opportunity to do so. And the same is true with all screeners, including adults, when you look at the question breakdown in the PHQ-9, which is the depression screen that we have, and we have about 2 million results with the depression or the PHQ-9. Once again, we often think of an earlier stage indicator of somebody with a serious mental health condition related to depression being suicidal ideation. But if you look carefully at this slide, you see that the suicidal ideation question, thoughts that you would be better off dead or hurting yourself, is the 8th most frequently positively answered question in the PHQ-9. What we should be responding to in integrated circumstances through screening and through earlier identification and intervention is in some of those other things on the list when people are feeling down, depressed, or hopeless, feeling bad about themselves, feeling tired of having little energy, having trouble falling asleep or staying asleep or sleeping too much. And when those constellation of symptoms are arrayed together, that's the time we need to be intervening if we're going to change trajectories of lives and move people away from suicide. So while 32% of the people in that prior slide basically talk about having suicidal ideation either half or nearly every day, and John is going to talk more about this kind of information, suicide, later on in his presentation. In fact, it's not equally distributed across age groups. Half of the screeners aged 11 to 17 report significant thoughts of suicide or self-harm. And we all too infrequently recognize what's going on with our kids. So here's something to keep in mind. It's not a question of there are serious mental illnesses, and those are the ones we need to be focused in on, and then some not so serious things that people will get over. As a matter of public policy, there is no distinction between a traditional serious mental illness and other mental illnesses. All mental illnesses need to be treated and taken seriously from the start. Just digging in a little bit more into the psychosis screeners, because often that is one of the conditions that people universally see as a condition that warrants serious attention for people. 73% of our nearly 300,000 psychosis screeners scored at risk for psychosis. Now, we only identify about 100,000 new individuals each year with schizophrenia for a diagnosis. So most of the people who will be diagnosed with psychosis are actually appearing in our screening population at an earlier stage of this process. And in fact, again, are not in denial about the symptoms they have. They're actually seeking help about the symptoms that they have. They're looking for us to do something on their behalf. And they are more likely to have been diagnosed already in the past with something. But I will say parenthetically, traditionally, they're more likely to have been diagnosed inappropriately with another condition. Now, the whole category of integration is so incredibly important to us because so many other organizations that advocate as we do on behalf of patients or individuals or people with the lived experience of those conditions come to us and say the overlap of mental illness and chronic conditions is really bedeviling to people. How do we figure out? We know what to do for somebody with a heart condition. We don't know what to do with the mental illness that comes along with that. our conference this year in June is being built around the overlap of mental illness and chronic conditions, because it's critically important that we look at these things within an integrated setting, because between 70 and 80% of screeners who have chronic conditions actually screen positive for a mental illness as well within our screening population, ranging across all chronic conditions and to these diseases in America. And in fact, people with chronic conditions have more frequently had a mental health diagnosis in the past. About half of them have, versus, as you recall, only about 1/3 of the overall general screening population. So when people, though, have a combination of conditions, and we need to do something for them. And one of the reasons why the healthcare system hasn't organized itself in a way to do so is because, as people say, they don't know, providers don't know where to refer people for care and services, because we don't have an adequate supply of behavioral health professionals, and they aren't adequately distributed around the country. But one of the things that we learned by talking to individuals who are help-seeking is that referral to care and services is only one of 4 things they are looking for. They are also looking for information and education, they're looking for engagement with peers, and they're looking for self-help tools that they can use to maintain their health and well-being. And even when we can't provide a referral to care and services, we can provide all of those additional other categories of support. And at Mental Health America, we're doing some of that. In 2018, we launched a screening support site. 1.5 million individuals had over 6 million views of content. And the content that we give people after they take a screen, whether they screen positively or negatively, which is customized for them, gives them information and resources in all 4 of those areas: the learning, the do-it-yourself tools, treatment resources, and connection with peers. And it makes a difference to them that we're able to do so from a perspective that they understand, because, as I mentioned earlier, words matter. I'm ashamed of the way I am. I want to die. I can't get out of bed. I'm feeling guilty. That's the way they talk about the conditions that they have. So our top pages are not clinical pages. They're pages like, I see ghosts or shadows. I'm afraid I'm going to kill myself. How do I get a service animal? And other kinds of things that help-seeking people are looking for. My concluding thoughts is that mental health problems are common and increasing, even as coverage and access improve. That screening is beneficial, and it can identify issues and intervention opportunities long before stage 4 in the mental health arena, just as in chronic diseases in general, that both children and adults benefit from ongoing screening and support, and that people with other chronic health conditions are at special risk. While support should be person-driven, the answer is clearly not in the further segregation and continuing segregation of our healthcare delivery system into health and behavioral health, but in the integration of care, services, and supports, because that's what leads to recovery. Thank you.
Thank you, Paul, for the presentation and for your leadership and commitment to improving early identification of mental illness. I think one key takeaway for our audience is that striking data on dual diagnosis and how the healthcare system can partner to develop a more holistic approach. To learn more about efforts to treat the whole person by integrating medical and behavioral health services, we're now joined by Suzanne Kunis, Director of Behavioral Health Solutions at Horizon Blue Cross Blue Shield of New Jersey. Horizon Blue Cross Blue Shield of New Jersey is investing in innovative partnerships to bridge gaps in access to behavioral health care and accelerating efforts to integrate medical and behavioral services, which is improving care coordination among providers and ultimately improving patient outcomes. Suzanne is leading Horizon's efforts, including developing new behavioral health programs and services, and she joins us today to share this important work. Suzanne?
Thanks, Catherine. And following Paul's lead, I do have a lot to cover, and I want to be respectful of everyone's time, so you're going to get the Jersey speak here to try to help to move this along. So let me just going to slide 2. It's just really a little bit about the organization. We are the largest and oldest health insurer in New Jersey. We cover over 3.5 million members. which represents about 50% of the insured market, or over 50% of the insured market. And the fact is, we feel as an organization very strongly positioned and really an accountability to help to make an impact here. And it's a huge opportunity for us with the coverage that we have in New Jersey. So I'm not going to go into a lot of this. Paul covered most of this, but I think that everybody needs to understand, and one of the messages that we continuously try to get out there is mental health problems are very common, but despite that, stigma stands in the way of people being willing to get treatment. We looked at some of the Mental Health America statistics, et cetera, and when you look at chronic illness, recognizing that about 59% of people have a comorbid physical health and behavioral health issue, when you start to look at the costs that are associated with it, we're talking triple the utilization of healthcare resources for individuals who are struggling with both mental health and physical health issues. So New Jersey is not unlike the rest of the country from my past experience, but what I can tell you is just focusing on our state, aside from stigma being one of the greatest challenges that we're facing, we have a significantly fragmented care delivery system, and in two ways. Limited coordination between physical health and behavioral health providers. And on the behavioral health side alone, there are significant gaps in services being provided. An example, if someone has a substance use disorder, they're heading off to a rehab. As they're being discharged from rehab, they're being given instructions to attend an IOP program in the next day. The person does not show up the next day and no one goes looking for them. So we're trying to address both the integration of physical and behavioral health, but also trying to address the issues within behavioral health itself. When you go to a primary care physician's office, you probably have a 7-minute office visit, which is the average, and in 7 minutes it's not easy to try to, or it's not even probably possible to address behavioral health issues on top of physical health issues. And aside from medical school rotations, most PCPs have not had any formal training around behavioral health and the effect of, the issues associated with comorbid conditions. We also are looking at patients from a holistic perspective. So we want providers to treat patients as people, not conditions. Thirdly, looking at access issues, we have, we know that about 60% of treating psychiatrists are over the age of 65. So as you can easily see what that's going to look like in the coming years. And child and adolescent providers, psychiatrists, we're talking 15 million kids needing service, and about 8,300 child and adolescent psychiatrists are out in the world. Some of them tied up with research and academics, et cetera, not necessarily treatment. We are in New Jersey are focusing attention with our provider partners on increasing psych residencies and actually doing a lot of training within the medical schools around the integration of physical health and behavioral health. But we need more alternatives to the traditional treatment providers, psychiatrists, social workers, psychologists. As Paul had indicated, there are not enough behavioral health clinicians out there to be able to address the need. So we're really spending a lot of time and energy around looking at different systems of care as well as different types of interventions that can occur at the primary care level. We have an out-of-network challenge, and I'm sure, again, many of the other insurers around the country are dealing with this, where we have lots of people leaving the state, heading to Florida, California, and Texas for treatment. And we have a long way to go to change things up, and part of our responsibility is how do we make care available here in the home community to really take any reason for people leaving the state off the table. The opioid epidemic, there's, the lack of evidence-based treatment and, substance use. We're real excited on the MAT front for opioids, but there's still a lot of work that needs to be done in this, the model of care, if you will. But in New Jersey, specifically as it relates to opioids, more than, on average, 8 people die every single day from an overdose. So not a good place to be. And again, making lots of effort to turn the tide, but still a tremendous amount of work to be done. Moving to the next slide. So as we were trying to develop our strategy about how we're trying to approach what we're doing here in New Jersey, we stepped back to say, what do we need to think about to ensure that the system of care that we have in place meets the needs of our citizens here in New Jersey? So the foundational elements are laid out here. A couple I wanted to mention quickly are treatment in the home community is clearly an important thing because going away and coming back, the issues are still the same. So we want to make sure that we have the supports here in the state of New Jersey. Patient navigation, we need to stop patients being lost between physical and behavioral health and between the various treatment modalities within behavioral health. And as Paul talked about, these are our most vulnerable members, so we really need to step up and go way above and beyond what has been done historically. Community-based services, we're very interested and have nice relationships with some of the CCBHCs here in New Jersey. It's these certified community behavioral health centers that were SAMHSA granted a couple of years ago. The scope of services that they're providing is incredibly positive, and the more we work for keeping people in the community and expand those types of programs and community-based services, the better our members will be. We're also looking at how do we remove obstacles to treatment. So aside from the fact that we have to deal with the whole treatment and recovery program for all of mental health and substance use, we want to make sure we're removing all the obstacles, homelessness, joblessness, as much as we possibly can in order to help people to get the services that they need and to live a healthy life. We are a commercial insurer as well as we have government programs business, but on our commercial side, we typically have not paid for services around housing supports, peer recovery, but we're totally shifting the dynamic here and trying to get into a new world on the commercial insurance side and trying to take some really positive lessons out of the community health world. So going to the next slide, as we developed our strategy, we wanted to make certain that we had solutions in place for everyone with needs across the continuum. Most of our efforts have been focused on quadrants 3 and 4, which are the high-end behavioral health, low-end physical health, and high-end behavioral and physical health, primarily serious mental illness. Again, what you'll see in a moment is we have solutions across the continuum, but really our greatest effort is looking at those individuals who are in quadrants 3 and 4. So with that as the backdrop, and with the focus on members in quadrants basically 2 to 4, let's talk a little bit about our integrated approach. So as I mentioned, we have solutions across the continuum, everything from health and wellness to SMI. And I wanted to give you a sampling of some of the work that we're doing. So this isn't all-inclusive, but it's an idea of some of the things that we're actually working on and have implemented or are on the way of, in the path of launching. So as you can see, the continuous services here, basically the intensity of resources and the level of engagement increases dramatically as you move along the continuum. And if you, again, we're highlighting here, according to the quadrants, the types of programs and services that we have implemented or will be implementing to support members in each stage of their illness or health and well-being. So we have, we've implemented a variety of pilots around integrating physical health and behavioral health. So we are supporters of the collaborative care model, and we reimburse for those services. We are working with provider organizations who have embedded clinicians in their primary care practices. We have hybrid models, the Cherokee model, as many of you are knowledgeable of. And then we've just recently being 2018, launched a program with Quartet Health. So we reimburse for collaborative care. We also reimburse for behavioral health screenings in a primary care setting. But we have a huge opportunity to do so much more in the way of education and training of the network. And we will be doing that in the coming months and years. I wanted to spend more time talking specifically around our Quartet relationship and our Able-to relationship. So I will do that in one moment, but before I leave this slide, I wanted to mention that we're also trying to look at episodes of care and other value-based financial arrangements with provider organizations. Behavioral health, and again, we're not unique here, but it's primarily been a fee-for-service world in the commercial side of the world. And we are trying to move that more from fee-for-service to fee-for-value. We've implemented 2 episodes over the course of the last year, one in substance use disorder and the second for inflammatory bowel disease, and really making behavioral health and physical health a single view for providers to help patients to be able to address the issues that they're facing as part of their disease. Okay, so Quartet Health, it's essentially virtual integration at a primary care level. The value prop here, Quartet leverages proprietary algorithms that they use. They take claim data from Horizon, run them through their algorithms, and essentially identify members with an undiagnosed or a latent behavioral health problem. This is a primary care physician-focused initiative, and what they'll do is, as a result of having done the claim analytics, they'll identify people who could benefit by having a behavioral health intervention. At the same time, there is also the opportunity for primary care physicians to surface patients to Quartet. And the reason we're doing this is, and we're making it available for any person that's being treated in a primary care setting, regardless of whether or not they're a Horizon member. We know that there are enough challenges in a primary care setting and enough priorities, and timing is not on our side, that we're trying to make certain that it's easy for primary care physicians to be able to say, I've got a patient, regardless of insurance, no insurance, what type of insurance, that they can actually surface to Quartet, and Quartet will connect them to behavioral health practices. And if there is an app that is used, so we engaged. Actually, we have over 1,200 primary care physicians in our first pilot and over 550 behavioral health practices in the pilot. And there is an app that's used between both practices, and so patients can be referred into behavioral health treatment from there, and then the behavioral health practices are able to communicate back to primary care that, yes, I have your patient. Yes, we have a treatment plan. Yes, there are medications that are involved. And it really changes the dynamic. I know for many, many years, primary care providers were afraid to do screenings because they didn't know what to do if the patient screened positive and how they would respond to that. Now we've got this tool in place where we are actually giving them the opportunity to surface patients, get them into treatment, and know on an ongoing basis what's actually going on with those patients. There is an expedited referral and coordination process between the behavioral health and primary care physician. And we started this off in January of 18. So the first year was really a build year. And as I mentioned, we've got over 1,200 primary care practices that are involved. And during that first year, Quartet has surfaced over 2,500 members to primary care as people who potentially could use a behavioral health intervention. And then 1,700 of our members were referred by the primary care provider into Quartet to get that patient set up with treatment. And then there were several thousand others that had no relationship to Horizon that actually were referred into behavioral health treatment because of the way we set this program up. It's a program that is currently focused on adults. We were, again, limiting it to a certain, we have 15 priority health systems that we have engaged primary care practices through. We are not at the point yet where we're able to see a demonstrable ROI because it was really the first year was primarily a build year. But we expect that we'll be able to analyze that by the end of the first year, by the end of this year. Having said that, we have seen such positive feedback from the provider community like we've never seen before. Most providers are not out proclaiming the value of a health plan, but there has been such great response to this, and we have lots of testimonials from providers that are actually utilizing the system that we've decided to scale this statewide, and we will be doing so in the coming months, even while we wait for the demonstrated ROI. The program is currently focused on adults, but our next phase is actually going to be working on the child and adolescent population. We're fortunate in New Jersey to have access to the Pediatric Psychiatry Collaborative, which helps with getting patients, it's funded by the New Jersey Department of Children and Families, and there's a way to get kids into treatment, but we want to take that to a much greater scope, if you will, over the course of the next year or two. So as much as Quartet was a PCP-focused program and a focused integration effort, we also have a relationship with Able2, and that is a member-focused program. So it's virtual therapy and coaching for people with depression, anxiety, and stress, and you'll see a little bit more of some of the programs that are available. But it's a telehealth solution, again, using claim analytics to identify individuals with chronic medical issues that could benefit by a behavioral health intervention. So it's an 8-week program, includes CBT and coaching via secure phone or video. They will have one coaching session a week by an individual who is a master's level clinician, and they will have a therapy session by a licensed clinical practitioner a second day during the week. So it's 2 visits a week. It's an 8-week program, and there is follow-up support services that are available to the members. But the focus of it is to really see how we can intervene and help people to deal with the issues that they're dealing with their medical issue, with their medical problems. The outcomes focus that we're looking at, we're measuring this by what is the impact on overall total medical expense, and secondly, and actually more importantly, the outcomes focus around what's happening with the scores that the individuals are completing over the course of that 8-week program. So the DAS scores, Depression, Anxiety, and Stress Scale, is utilized, and we monitor that over the course of the program and into the future. We are continuing to expand the program. Again, people that go through the program and graduate have greater than 97% satisfaction with the program. And so we think we're trying to do the right things by having a PCP-focused intervention, a member-focused intervention, and then lots of other things that fall around both of those. The next slide just briefly shows you the extent of the programs that are available under our Able To model, but it's really dealing with all kinds of issues that you would deal with in life, including traumatic life events, your medical condition, and then just basic psychological distress. Okay, so I mentioned earlier we have a focus on substance use disorders and the opioid crisis. It's a huge area of focus, and we've made a significant investment as an organization in really making certain that we are stepping up and doing all the right things. We're focusing our program around education and prevention, treatment and recovery, community engagement. We're piloting a lot of different solutions, and the reason is this is such a huge challenge in the state that we really need to just throw everything at it to see what possibly can be done to help individuals to get into recovery and to stay in recovery. Our pharmacy program is quite robust. Our lock-in has been quite successful. As you see some of the highlights here, we have prescriber-focused risk identification programs. We have a prescriber toolkit to help with educating providers around best practices. We're working with the DEA and the Partnership for Drug-Free New Jersey and so many other community organizations to really hone in on what's happening, what are we doing as key stakeholders in the state, and coming from all walks of life to be able to try to get this crisis under control. And then we're really emphasizing best practices, MAT, medication-assisted treatment, and helping to actually establish services in areas of the state that where it doesn't exist. So as you can see, as I just mentioned, increasing access to medication-assisted treatment services. We will have a teletherapy solution set up shortly that will be specifically focused on substance use disorders. We've actually partnered with an organization called MAP Health Management. We're doing a pilot program, and it's a technology-enabled peer support where at the point of discharge from a higher level of care, inpatient or residential type of program, as well as at the point of entry into outpatient treatment programs, the individuals will have the opportunity to engage with a peer who is in recovery, and they're certified peers, and they provide a structured outreach program, 4-time contacts during the early months, and there will be an outreach from the person in recovery who is actually the peer to the individual who's struggling with getting in and staying in recovery. And then that patient, as well as their families, will have 24/7 access to the peer. We thought it was very important that we made sure that the families or support system were able to get into the peer whenever they would see one of their loved ones actually beginning to go down a slippery slope and actually help to bring them back and re-engage in treatment. So lots going on there. Peer support, and again, I know, Paul, you had mentioned about it. We are huge supporters of peer services, not just for substance use, but also for mental health. And again, typically not a service that has been covered under commercial insurance, but we're trying to change things up to really include a whole new scope of services that will do the right things to get people the care that they need and then into recovery and stay in recovery. And in the end, you do the right things and the money will follow. And then lastly, I wanted to spend time on this program that we are going to be launching this summer, and we're really excited about it because we think it's very different than what's actually been sitting out there and addressing all the challenges that we've been facing. So it's called our Integrated System of Care, real creative title, but it's targeting the most vulnerable members that we have, which are the most complex member needs. So the core of the program is our behavioral health integrator, and it's really a center of care. The first one that we're working with is an organization that is one of the CCBHCs here in New Jersey. And what their role is they're going to continue to provide the full scope of services they do presently for members who actually approach there for treatment, but they're also going to be doing a higher level of service in terms of patient navigation. That's really what we're trying to focus on here. Our objectives are to reduce the delivery system fragmentation, increase access by improved navigation of members. We don't want people to keep getting lost in the system and fall through the cracks, and improve the quality and reduce total cost of health care. So for the last 12 to 18 months, we have focused on developing this model. We've identified the integrator and the roles and responsibility for the integrator, which, again, it's on all aspects of this. So our model of care, the ecosystem, includes not just behavioral health issues, but it's really bringing into play the physical health pieces and delivery system, as well as addressing the social determinants that we need to address to ensure that people are able to engage in treatment and to stay in treatment. So we've identified our integrator for our pilot. Again, it's in one small area. And we've also identified a health system partner, one of the major health systems here in the state. And they currently work together on a very small basis, but what we're doing is formalizing this approach and really making certain that we have all of the tools in place that we need to, including feet on the street, et cetera, to be able to get people into treatment, regardless of what their treatment issues are, make sure that they attend treatment services, make sure that we're tracking outcomes, making sure that they're fully engaged as well as their family, and doing whatever we need to do to try to change the trajectory of illness for people that are in the state and in this pilot program. We did seek expert input. We approached a couple of nationally recognized individuals and organizations for their input and had received great feedback and support for the program that we're launching, and we're expecting to be live this summer. So it's pretty exciting because if things go as well as we're hoping that they will, then we are hoping ultimately to scale this statewide. But we're going to start in one small corner of the world and go from there. To give you a sense of what we believe can happen, so we have as I mentioned, a behavioral health practice that we've identified, and we have a health system that we're working with. Today, there are 77 people who are actually being seen in both systems for physical health and behavioral health. Prior to actually even implementing some of these changes, we knew that we were partnering with the right people because as you look at the average total PMPM, those individuals who had not visited this practice and potentially not had behavioral health services at all, their total PMPM is 15% lower than those who did not visit that practice. When you look, and then we split it into the physical health PMPM and the behavioral health PMPM. So as we mentioned earlier, costs are generally 3 times higher for individuals that have a comorbid condition. And here we're looking at, again, in the early sample of work that's already being done on a limited basis, we're seeing a 35% lower PMPM on the physical health side of the equation. So again, small numbers, we understand that, but we think it definitely reflects evidence of that strengthened integration between physical health and behavioral health really will improve overall outcomes and reduce overall cost of care. So our next steps here are that we are going to be launching and we'll be monitoring over the course of the next 6 to 12 months and waiting to see what the results are. It's been a journey getting to this point, but we're really excited about the potential. And with that, I'm going to end my presentation, and thank you for your time.
Thank you, Suzanne. Suzanne highlighted several promising ways that a health plan can partner with providers, with their members, and the community to break down barriers to mental health care by reducing stigma, improving access to care, while improving health outcomes and reducing the total cost of care. The rising cost and burden of mental illness is a significant concern for everyone, especially the federal government and the states. Medicaid is the largest payer for mental health services in the U.S. Our next speaker, Kitty Purington, will share an update on state approaches to improving behavioral health care. Kitty is a senior program director at the National Academy for State Health Policy. She has over 20 years of experience working on state Medicaid policies to support behavioral health needs, including overseeing the development of the Medicaid behavioral health home model for adults and children in Maine. Kitty?
Great, thank you so much, and good afternoon, everyone. I really appreciate participating in this discussion. So I'm going to be talking about the state policy role in improving mental health services and kind of the unique role that states have in this area. I'll talk a little bit about some of the key challenges facing states and also talk about the specific policy levers that we're seeing states use to address just a scope of challenges in delivering or supporting effective systems and services for people with behavioral health needs. So first, I wanted to just review very briefly why states really care about mental health and are very invested in these issues. First, states, as Catherine mentioned, incorporating Medicaid spending are really significant payers in the world of behavioral health services and supports. And in fact, Medicaid is the single largest payer for mental health services in the U.S. And state systems developed a traditional role of providing care to people with serious mental illness. From the 19th century on, they were really seen as essential elements of the system of care for people with serious mental illness in terms of supporting the asylums and institutions of the 19th and 20th centuries. Following the deinstitutionalization of individuals with serious mental illness in the 70s and 80s, this view of the state function, of states being core to supporting individuals with mental illness, is still very much alive in the policy world, and in some unfortunate ways, as evidenced by what is known as the IMD exclusion, or the unappealingly named Institutes for Mental Disease policy. So this policy prevents state Medicaid agencies from not being able to use federal funding to pay for treatment within state mental health institutions, as opposed to other settings, other inpatient settings. This policy of states really being the primary locus for mental health care is also very much reinforced in the distinctions in benefits and approaches between Medicaid and Medicare, which Medicare until recently paid only 50% of claims for mental health treatment, and still, for a number of reasons, still offers a much more limited benefit package for people who have mental health needs. So states are increasingly recognizing that mental health is a cost multiplier for their programs, and the data is very clear that having a mental health diagnosis increases the cost of care, largely for physical health diagnoses, enormously. Medicaid spending for behavioral health diagnoses is roughly 4 times higher for spending than those without these disorders. And people with mental health diagnoses are much more likely to have multiple chronic conditions, use more services such as emergency room and inpatient services, and more likely to have readmissions. Generally, having a mental health issue coupled with many of the systemic challenges that people with mental health face really makes it a lot harder to do a lot of things. It tends to make people poor. It also often comes with medication regimens that make people prone to metabolic diseases like diabetes. So all of these factors have a very significant impact on the mortality rates of people with mental illness, serious mental illness in particular, who die on average 15 to 20 years before their peers without these disorders. When we talk about state mental health systems or state mental health policies, we are really talking about two quite different systems of care. There's a lot of overlap, but they tend to be, from a state policy perspective, fairly distinct for a number of reasons, with different payment policies and different approaches at the state level. So on the one hand, in the first column, I have what I'm calling here general mental health services, for lack of a better term, which describes the capacity really for primary care providers to deliver behavioral health treatments for a range of conditions that can be successfully identified and treated in more integrated settings. So this approach to mental health treatment does not necessarily, it doesn't necessarily align neatly with diagnoses, but it can include things like, as we've heard, depression, attention deficit disorder, anxiety, and other disorders that with some support can and really should be addressed early and effectively within settings like federally qualified health centers or school-based health clinics and general primary care. But there are surprisingly a number of barriers to supporting treatment in these settings, and states over the past 5 to 10 years have really been keenly interested in promoting the development of more integrated models for Medicaid populations who are more likely than other beneficiaries, commercial beneficiaries, for instance, to be dealing with a behavioral health diagnosis. And state policymakers have really been engaged in identifying policy levers to help build that integrated capacity in primary care, including support for assessment and screening, and the ability to have multidisciplinary teams that can include care coordination and oftentimes a behavioral health specialist. Sometimes that behavioral health specialist can be co-located when feasible, but also looking beyond the walls of a primary care setting and building supports for how primary care practices can really effectively link with and refer to more specialized care when needed. Also, states have been doing quite a bit of investment in pushing out integrated data, Medicaid data, and looking at other ways that technology can support practices to have a better connection to behavioral health services and supports, but also a better perspective, a more comprehensive perspective of an individual patient's needs that's getting treatment from their practice. Somewhat in contrast, people with serious mental illness, very generally speaking, typically receive mental health treatment through specialty service providers that rely very, very heavily on Medicaid and on state funding. These systems are really creatures of state Medicaid and state funding, and as such, states are very involved in defining the service array, defining medical necessity or eligibility criteria for these services, which often includes a diagnosis plus some sort of additional functional criteria that indicates a more intensive need for services. And the services provided by the specialty mental health system are going to be a broader range of services, more intensive services that typically or generally speaking are not going to be found certainly in Medicare or in commercial insurance packages such as peer supports, supported employment, supported housing, and other things that can assist people to recover and live effectively in their communities. Because this is really a broad area of concern for states, and there are a number of policy issues that states are very involved in. There are things that present persistent challenges as well as some things that are more emerging, particularly in relation to the opioid epidemic and SUD challenges generally. For states' work in promoting integrated care for their Medicaid populations, promoting and sustaining services across primary settings, and especially safety net settings is really an ongoing priority and an ongoing challenge. Understanding what primary care and related settings really need to address mental health diagnoses, how these services can be supported effectively and incentivized, has been the focus of a lot of work by state policymakers over the past few years. As mentioned previously, the behavioral health workforce is also a huge concern, and I think integrated care is often looked at as a way to leverage the workforce more effectively so that state systems can increase access to behavioral health. But it's particularly challenging to support a diverse workforce and a behavioral health workforce that can address the particular needs of older adults, children, and also the needs of people who live in rural areas. Within state sort of more specialized mental health systems, states are really realizing that mental health systems, which are fundamental to overall health, need to be able to participate in state health reforms and payment reforms. And in many states, mental health systems have been the purview of smaller providers who operate on very narrow fiscal margins, and as such are very challenged to participate in payment models involving risk, for instance, or they may not have the data capacity that large medical systems are able to purchase to support their practices. So there's a lot of investment to be made within these systems to support evidence-based or best practices, to support the use of data and health information technology, and kind of the overall capacity to participate in value-based purchasing and state health reforms. There are certainly organizations that are large and sophisticated and are doing this work, are participating in these kinds of state health reforms and have a lot of this capacity, but there are probably more that are not there yet. In addition to these emerging issues, states have a long-standing interest in supporting a continuum of care for individuals with serious mental illness that can help avert crises, that can maintain housing, that can avoid corrections involvement, and other outcomes, other adverse outcomes that can result when people with these often very significant challenges are not able to access care in a way that is timely and appropriate. So it's an ongoing challenge for state policymakers, exacerbated by things like the IMD exclusion mentioned earlier, and the challenge of managing state budgets and limited resources. So also across both general and specialty mental health systems, states are really grappling with the so-called diseases of despair and how to balance these scarce resources and at the same time invest a lot of increasing amounts of federal funding in ways that can sustain capacity. So we do see states looking at the foundations that they have built through integrated care as a way to support things like medication-assisted treatment to do that more effectively, and also looking at ways that both general and specialty systems can do a better job of recognizing and understanding how social determinants come into play here. So my last two slides provide a brief overview of the varied policy levers. These are kind of the key policy levers that states have to address some of these challenges, starting with support for integrated care that is happening in primary care practices and FQHCs and places like that. And for, obviously, as we've discussed previously, for a long time the prevailing thought was that states should keep mental health and physical health benefits at the Medicaid, the state level separate, with the thinking that in a capitated MCO environment, mental health treatment would receive short shrift. That pendulum is definitely swinging back with more states contracting for both physical and mental health services in a unified contract, with the thinking that this will remove some of those unintended siloed consequences and promote better clinical integration of care. These are by no means all of the states that are engaged in this, but certainly Arizona, Florida, and Washington are a few outstanding examples, but there are many other states that are moving in the direction of contracting for an integrated package of services as a way to get at a more comprehensive integrated service array for people, regardless of where they seek care. States have also taken advantage of Medicaid 1115 waivers and sort of a more specialized waiver known as delivery system reform incentive payments to reorient their systems of care to have a more integrated approach and capacity. So in states like New Hampshire and New York, we are seeing significant investments in primary care and things like care coordination and other supports that can help primary care be more able to address the mental health needs of their Medicaid populations and be able to link them more effectively to the services that they may need. So these, New York and New Hampshire, as well as other states, are piloting things like incentive payments and quality improvement initiatives and other strategies that can help move the needle on mental health outcomes and mental health access. The state innovation model program, a significant federal initiative, has seen similar investments by states. In SIM, there were two rounds of states were awarded a pretty significant amount of funding for 3-year pilots. And looking across these states, I would say a majority of them, of the state initiatives funded under this program, have integrating behavioral health as at least a component, if not a focus. And SIM states are using those funds for things like provider training, a lot of development of capacity at the provider level in screening and treatment and care coordination. States are using tools like peer-to-peer teleconsulting, the ECHO model, creating integrated data analytics for providers that may not have access to them, and other supports with a goal of improving that integration at the primary care level. Health homes are another somewhat newish Medicaid option that many states have embraced that also allows states to provide a more comprehensive package of care. So this model, the health home model, supports team-based care and can serve almost as a wraparound set of services for a primary care practice to, again, include that care coordination piece, which can be so vital in helping an individual manage not only their mental health condition, but any comorbid conditions. It allows primary care practices, or can allow primary care practices to access case management, peer navigators, and other supports to assist people with complex needs in a primary care setting. Some of the key policy levers on this slide, they're the same as the previous slide. The policy levers may be the same in some cases, but states are maybe using the policy levers in different ways to get at improvements in the specialty mental health care that they deliver through Medicaid. So, for instance, while Medicaid managed care is a common tool, we do see states develop more specialty managed care programs to address the physical and behavioral health needs of individuals with more serious mental health conditions. So in states like New York and Arizona, they are developing plans that are integrated plans. They provide both, they provide physical health benefits, but also a much more robust set of services to address the needs of people with more serious conditions so that they can access both the range of services in the specialty mental health system, but also have their physical health care integrated. A major trend for states right now in terms of behavioral health is the use of 1115 waivers, a Medicaid vehicle, to be able to do significant reforms in substance use treatment. And a number of states have taken advantage of 1115 waivers to be able to waive the requirement or waive the prohibition on using federal payment for IMDs. And this is allowing states to bring in or to be able to incorporate things like residential treatment for SUD into their Medicaid service array. And a similar opportunity exists to use these 1115 waivers to expand the continuum of care for people with serious mental illness as well, although that is more recent and just has not had as much uptake, but it does show some promise in being able to have additional flexibility to develop a more comprehensive continuum of care. Similarly, states are using SIM as a way to invest in behavioral health, and states have also had success using SIM to support the adoption of health information technologies in places like community health centers, which, as I mentioned, have not typically had the opportunity to have the resources to develop, to implement a health information or an EHR, and may not have been able to access federal funding that supported that. So some states have used SIM as a way to build that capacity and also create stronger linkages between community mental health and primary care. And health homes have been very popular as a state policy tool to design new models of care, more comprehensive care for people with serious mental illness, similar to the health homes that support primary care. States are using health homes as another team-based model to provide better integrated care for people with serious mental illness, and also be able to build in things like peer supports or peer navigators. These health home models we're finding are increasingly, I would say, replacing traditional targeted case management services as a more flexible approach to provide that kind of service. And finally, 1915I state plan amendments are another tool that states have to explore ways to provide more comprehensive community supports to individuals with serious mental illness. The appeal of the 1959 option is, again, states are always looking for flexibility to be able to address the needs that are particular to their states. And the 1915 option can help states get at some of the social determinants of health that really disproportionately affect people with mental illness. So through these amendments, they can fund things like housing and employment supports that can assist people in ways that go beyond medical care and medical treatment, and can ultimately support recovery and support the ability of people to maintain a life in their community. So thank you very much. I believe that's my last slide. These are some additional resources that can be found at our website, and really appreciate the opportunity to speak with you.
Thank you, Kitty. It was really clear from your presentation that states are implementing innovative approaches to improve behavioral health and how important this is in order to address the diseases of despair that Kitty mentioned. We'll hear next more about these diseases and deaths of despair from our next speaker, John Auerbach, President and CEO of Trust for America's Health, or TIFA, a prevention-oriented, Washington-based policy, advocacy, and research organization. John has held senior public health positions at the CDC and as both Boston's and Massachusetts State Health Commissioner. At each level, his work involves efforts to promote health and prevent suicide and other leading causes of death. Under his leadership, TIFA's Pain in the Nation work has drawn critical attention to deaths of despair in America and facilitated dialogue on how to advance evidence-based strategies to promote wellness. We're pleased that John is with us today to share this work. John?
Oh, thank you, Catherine. I'm going to focus on one particular aspect of mental health trends, and that's the increase in suicides. Suicide prevention is one of several health topics that are priorities for us at Trust for America's Health, and we work with Congress and the administration as well as with states and local government and the general public on this issue. And our work is generously supported by the Wellbeing Trust, and many of the materials and lessons I'm about to share reflect their commitment and their expertise. As we've already noted, there's been a striking increase in terms of the number of suicides in the last decade. And this chart just shows it with the dark blue line. We've gone from about 29,000 to 47,000 suicides annually in the last 20 years. And over the same period of time, as shown by this chart, we've seen a rapid increase in the number of deaths from alcohol and from drugs. And these three causes of death are not coincidental. When we consider the root causes of each, we see notable similarities. And this suggests that we consider them in relationship to each other, especially when we emphasize prevention. Therefore, while I'm going to focus on suicide, I'll return to the topic of the common upstream factors associated with the three causes of death. In addressing suicides, we also believe that a comprehensive approach is needed, one that starts with a detailed look at the data, at studies that looks at the evidence about risk factors and the ways of reducing those risk factors, and that looks at the role of multiple sectors, including healthcare and public health, but also education, business, housing, and public safety, just to name a few, and thinks about the entire spectrum of need, from infancy and childhood through adulthood, and from primary prevention to emergency intervention. Our series of efforts under the title Pain in the Nation does reflect that approach. And you'll hear me talking a good deal about policy. With regard to suicide specifically, this chart indicates that all demographic populations have been affected and are seeing increases. The increases you see in this slide are those that took place over a 10-year period from 2008 to 2017. But while all are affected, some have had the largest increases, such as those under 34 years of age, Black and Latino populations, those in rural areas, and women. Of course, it's worth noting that some of the populations have higher overall rates that these increases were built upon, such as white men, white populations in general, and men. And these rates still are higher, even though for those populations, even though this chart may show them having a lower increase. Looking at the data by subpopulations actually is important for a number of reasons. One is the importance of promoting equity, and while all may be affected by the risks associated with suicide, other forms of mental health, there are important differences that exist with regard to access to high-quality care. Low-income people and people of color in general face elevated challenges. And it's important to focus on reducing some of the underlying causes of trauma that may contribute to suicidal risk, and these may be more likely to be seen in certain subpopulations. These underlying causes, including such things as adverse childhood experiences, which are more likely to affect populations with more limited economic resources or populations facing systemic discrimination, are noteworthy if we are to pay attention to the promotion of equity in our work and make sure that all people have a fair and just opportunity for wellness. The next slide also just shows that those differences really extend to states. This chart, actually the chart that you're seeing there, combines the risks associated with alcohol, drug, and suicide deaths, and you can see that there are significant differences. The states with the highest suicide rates are Montana, Wyoming, and Alaska. That would suggest that there are particular challenges in what are sometimes referred to as frontier states that may have major geographic barriers to care and specific types of risk factors, including access to guns, that require specific approaches to address the conditions they face. When a suicide attempt is made, it's usually the tip of the iceberg with regard to risk, and our comprehensive approach attempts to think about all the ways that intervention could have been possible. This pyramid reflects that, with the top section reflecting those who actually die as a result of suicide, and the bottom reflecting a much broader section of those who are at elevated risk because they've endured some form of trauma or adverse childhood experiences. And in between are escalating conditions and diagnoses that reflect greater and greater risk of suicide. This conceptual image is a reminder that we can intervene long before someone is suicidal by working at those lower stages of the pyramid. A complementary pyramid reflects the various stages of risk and suggests when and how we should best intervene with, for example, attention to changing the conditions in people's lives at the bottom of the pyramid, and higher levels of the pyramid assume that the adverse experiences may have already occurred, and they focus more on screening and building resiliency. But a focus on all levels of the pyramid is part of that comprehensive approach I was mentioning. We in public health really think about upstream, and here's just some of the categories that we think about when we try to work not just within the healthcare system, but also at the community level and at the family level. Now, I'm not going to mention much about the what are the optimal approaches within clinical settings, because you've already heard of those. I will just mention in this regard that a policy that really matters a lot is access to comprehensive health insurance, and the Affordable Care Act provided that for an additional 20 million people who, as a result, may have easier access to mental health services, including those that can help to prevent suicide. And that was built as well on the work that was done in the Mental Health Parity and Addiction Equity Act of 2008. And this notion of parity, I think, as a policy issue is important for us to keep our eye on, because even though that act was passed in 2008, there still are challenges with regard to parity and coverage. And great work is being done by Patrick Kennedy and the Kennedy Forum to pay attention to the efforts that we still need to focus on policy level to ensure that parity becomes a reality in the provision of high-quality mental health services. Again, we covered the issue of integration, so I'm just going to skip over this slide. I will mention that an excellent set of services or a model for how to address issues related to suicide have been developed in the Zero Suicide Framework at the Zero Suicide Institute at EDC. I won't go into it here other than to say that it provides an excellent model, and that people interested should Google that at Zero Suicide in EDC to receive the materials related to it. I do want to instead focus on more of the upstream, more of the social determinants for consideration. And I'd start by saying that it's when looking at suicides, it's important to think about the methods of suicides, because that suggests some of what needs to occur both in the clinical setting but also at the policy level in addressing some of those social conditions. This chart, for example, shows the leading methods of suicide deaths, and you can see that the light blue line related to suicide deaths from firearms is by far the highest and has been increasing steadily over the last decade and longer. The red line refers to suffocation and hanging, and that too has been increasing rapidly over the last 10 years. So paying attention to those causes of the methods that are used in suicides is important for both clinical and policy reasons. Clinically, this is an example of why it can be important to pay attention to those. A study was done which indicated that when clinicians screen and counsel people who may have mental health diagnoses or a suicidal ideation, they can reduce the risk by focusing on ways of making both guns less accessible or potentially dangerous medications less accessible. And as you can see from the chart, counseling had a significant impact in terms of reported behavior. This slide provides, I think, some surprising information about suicide in that it indicates that when, according to a recent analysis by the Centers for Disease Control, that more than half of people who die by suicide didn't have a known mental health condition prior to their diagnosis. CDC found that this was particularly true for men, and that those men were most likely to die from firearms. This slide focuses a little more deeply on, well, what were the precipitating circumstances in those deaths where there wasn't a prior mental health diagnosis. And they found that there was a range of circumstances that precipitated the suicide, and those included things like relationship problems. About 42% of the suicides in this category had those risk factors, or financial or housing-related problems, adding to about 20%. And as a reminder that suicide and drugs and alcohol misuse are related, about 28% had a substance abuse problem. When I was the Massachusetts Public Health Commissioner, we actually found that among those who had the highest rates of suicide were those returning from armed services abroad. And we also found that those recently released from correctional facilities had significant high-risk behaviors that place them at risk as well. And that suggests that in major transitions from stressful situations, special attention should be paid to those populations. To address the range of conditions that CDC found among those who died of suicide, a number of responses are needed. And certainly there should be screening for those who may be going through those situations, and reference and linkage to appropriate services, as we've heard. But other approaches could address the underlying causes themselves, such as developing policies that promote housing stability, economic opportunities, and strong family supports, as well as criminal justice reform. And there are a number of materials that have been developed for people who want to work at that upstream level. This slide illustrates one of those. It is a new report called Promoting Health and Cost Control in States, or FACTS, and it provides 13 evidence-based state policies, many of which will lessen the social determinants associated with suicide or with substance abuse disorders, including the ones that I was just mentioning that CDC identified as part of the circumstances prior to a suicide. They do such things as lessening housing and economic crises and combat some racial and other form of discrimination. Other evidence-based approaches that are worth noting include the Centers for Disease Control's Health Impact in 5 Years, or High Five initiative, and the de Beaumont Foundation's City Health Initiative. Each of these can be Googled for their research tools and technical support. And of course, we would be helpful to contact anyone and let them know of how to reach those materials. So finally, I would summarize by saying that when thinking about suicide and truly thinking about mental health in general, a multi-sector approach is best. And those sectors certainly include clinical care and public health, but they also do extend to other sectors like education, the criminal justice system, housing, economic opportunities. The blue chart you see on this slide is from the Centers for Disease Control and their excellent package on preventing suicide, and they illustrate that there is a role indeed for every sector and for each individual in terms of considering how to lessen the likelihood of suicide or a negative outcome, how to help in terms of getting people services and screened and connected to services, but also how to think about the ways that we can have an impact on the conditions in people's lives so that we promote health and well-being and reduce the likelihood that people will end up needing many of the mental health services that we've been discussing as essential for those with symptoms. So in conclusion, I just want to say please check these various sources for additional information. Our website is one site that has a comprehensive set of resources available. So Catherine, thank you very much, and back to you.
Thank you. We're going to jump right into Q&A. Suzanne, going back to your presentation, we had a couple questions come in about wanting some more detail on your use of predictive analytics to identify members with behavioral health conditions. And could you talk a little bit about how if you're using claims or how you're identifying the potential need for behavioral health services?
Sure, thanks. So a couple of things. So I mentioned our relationship with Quartet Health, and we actually provide claim data to them, and that's where the algorithms are run in terms of identifying individuals with undermet or unmet behavioral health needs. So theirs is really more of based on what's happened in the past. Able to, as I'd mentioned, similarly runs algorithms with a member-focused program and identifying individuals with comorbid conditions that could benefit by an intervention. Within Horizon, we actually have our own predictive models that we use around people who, for example, we're looking at things like readmission, hospital readmission and individuals who are at risk there. We're looking at opioids and patterns for individuals who are actually suffering from various opioid-ish challenges, whether it's ever been diagnosed or not, mostly not, and providing interventions associated with that. But yes, it's a combination of claims, other data that we get in that we use internally from external resources, and everything kind of compiled into our engine, if you will, for predictive models.
Great, thank you. This question is for the full panel. We talk a lot about integrating mental health into physical health, but are there policy level discussions or things happening in your communities about integrating the physical into behavioral health settings?
Hi, this is Kitty, and I do think that is the work that many states are undertaking as part of their behavioral health zone model. And oftentimes linking to primary care, looking for ways to provide direct links from community mental health centers to primary care. Some are also bringing primary care into community mental health centers, although I think that in many ways that's a tougher model because first people may want to continue to access their own primary care provider as well as their own community mental health providers, but also it's a more challenging business model to really be able to support full primary care within the community mental health setting. States are looking at ways to fund nurse practitioners and also develop a more integrated capacity for case managers and the behavioral health clinicians who work in those settings.
This is John. I would also add that there's a long list of regulations and financial barriers, sometimes capital barriers to that integration. And I think that the states that have made the most progress have figured out ways of reducing those regulatory barriers, increasing financial incentives, because these busy organizations, both on the behavioral health side and on the primary care side, really need guidance and assistance in terms of the integration. It's a complicated field. It's not easily done without policies in place that make it easier at the state level.
This is Suzanne. Just in New Jersey, I can speak to what the work that's been done by the certified community behavioral health centers that have been under the SAMHSA grants, and the one that we're working with in our pilot, they have done an incredible job of bringing a behavioral health home alive within their behavioral health practice. And one of the things we found, and they found, is that so many of the individuals that actually would benefit by services of a behavioral health home don't have primary care physicians already engaged. So it's really, in many cases, if there are primary cares, you don't want to disrupt those relationships. You want to establish real coordination and collaboration. But many of these folks, especially on the serious mental illness side, really have not had primary care relationships in the past. So it's really been a good opportunity to make those connections.
Great, thank you. John had touched on some of the issues in, rural parts of the country, and Suzanne had also mentioned, the online tools that you're doing. We had a few questions that came in just about kind of the unique challenges for rural mental health and what some of the solutions are, and also just if any of the other speakers want to comment kind of on the use of technology going forward in the mental health field.
Are you asking me that, Paul?
Sure. Do you want to start, Paul?
No, well, I mean, that's one of the things that we're doing with our online screening program, and there are a number of others who have used technology to, for example, just, do historically, phone sessions for therapy, but there's a tremendous amount of activity as we've discovered. So we do online screening. It's very easy to take it to scale. It's very inexpensive, and do online follow-up to services, many of which are delivered in virtual environments. The understanding that people need to have is that we are not bound by physical neighborhoods in the way we were even 5 or 10 years ago, and especially our young people are living in virtual neighborhoods that are nationwide and worldwide. So there is going to be a tremendous amount of activity in these virtual environments, and with increased use of technology. It's something that states should be interested in from a regulatory perspective as well as a promotional perspective. It's something that the nation as a whole should be interested in terms of the building and the development over the next 5 to 10 years of our healthcare and behavioral healthcare delivery system, particularly the integrated one. But it will not happen, and technology use will not move further if we don't address the inconsistency in federal rules between things like 42 CFR Part 2, which establishes a different privacy standard for substance use treatment from that which HIPAA provides for nearly everything else. If we don't get alignment around the rulemaking and conform, for example, 42 CFR Part 2, these archaic structures to HIPAA, something that was developed 20 years ago, we will put significant roadblocks and obstacles to the use of technology, particularly technology that allows people to cross physical state lines and other physical barriers.
So this is John. I think we've talked to a number of people in frontier states and rural states who have highlighted some innovative approaches, and certainly those include telemedicine, where that is being used. People are often identifying the importance of such services being reimbursable. In some instances, that is a challenge for them to be reimbursable. They are also highlighting that there needs to be training and support in terms of how to handle that kind of intervention in terms of the clinical practice, the confidentiality rules. So training is identified as very much needed. A second approach that has been tried in rural or frontier areas is using non-conventional satellite sites to offer services, and those include non-clinical sites where there may be a couple of times a month, for example, using some office spaces that are available in a community where people have an easier time getting to, and that instead the clinicians can come at designated times to that facility. There, too, the importance of reimbursement and licensure requirements for satellites is something that needs to be a part of state planning and reimbursement issues.
Thank you all for those comments. We are out of time, so I do want to thank our panel of speakers who took time from their busy schedules to be with us today, and to thank our audience for joining us. We hope that you leave with some ideas to take back to your work and to your communities and that you've been inspired by this panel today and the fantastic work that they're doing across the country. We'd appreciate it if you'd take a moment to share feedback on this event by completing a brief survey, which can be found on the bottom of your screen. And we hope that you'll also look for announcements about the third and fourth webinars in our series, where experts will share more about suicide prevention initiatives and also efforts to increase access to evidence-based treatment for addiction. Thank you all again for joining us today.